You can read on these drugs. They're not quite as popular, not as used. They're very much like your sulfonylureas. Okay, they can cause low blood sugars, hypoglycemic effects. These drugs, this is your Actos and Avandia. They decrease the insulin resistance of the cell, making them more sensitive. These guys really are not used much, but they do not cause drops in blood sugar. And when you're looking at these drugs, and just so you know, these are also all listed in your book. I'm flipping through the book right now, so if you feel like you need additional information on these particular drugs, so the alphas are listed on page 1163. Your book says they're known as the starch blockers. They delay the absorption of the carbs in the small intestine. Your DPP-4s, these are newer drugs, not as familiar. These are not utilized as much. The general population is not as familiar with these drugs, but they work a little bit differently. They actually help to stimulate the release of the insulin from the pancreas and help decrease the production of glucose in the liver. You will find a lot of times people are on combination meds, and that's because they work in different places, as you can see. Maybe we need one that helps, stimulate the release of insulin. Maybe we need to have one that helps make the cell more prone to take up the glucose. Maybe we need to have one that helps break it down in the intestines, and so you can have combinations of oral meds. There are times that type 2 diabetics, yes, they do have to take insulin, and so these drugs can be worked in conjunction with insulin. You guys learned about insulin in type 1, in MP1, and so I'm going to have you guys just kind of review this on your own. You need to know the onset, peak, and duration of the drugs. You need to remember the principles of how to draw up the drugs. You need to remember the principles of how to inject the drugs. Just a chart to remind you if they're rapid, short, intermediate, long, or if they're a combination insulin. A graph that shows you the onset, peak, and duration. This is cute. It just has some little ditties about the rapid acting insulins, reminding you, for instance, that they have a rapid onset and that you want to make sure that there's food readily available, that you can mix regular with all the other insulins, that you can't mix like Lispro only with N or Humulin U. So you can note that regular is the only one that can be given IV. These two phenomenons are actually outlined on page 1163 in your book. They have to mainly do with what happens with our patients at nighttime. So for instance, the first one, maybe your patient gets too much insulin prior to going to bed. This produces hypoglycemia. The patient actually has a hypoglycemic episode during the night, but possibly does not recall. So you need to, if we suspect this, check their blood sugar, maybe like between 2 to 4 a.m. in the morning. Do they have a headache when they're getting up in the morning? And ask them, did they experience night sweats? The problem with this is that the patient experiences hypoglycemia. The body recognizes this, responds to it, and then in the morning when the patient gets up, they have hyperglycemia because of the body's reaction to the episode, and the patient documents this, and the physician could actually increase insulin doses based upon this, which could end up being a real issue in the middle of the night. And the dawn phenomenon is also characterized by hyperglycemia in the morning, okay? And it has to do with the hormones being released in the early hours of the morning. And so the one thing is we have to differentiate between the two of these. And so one way to differentiate is checking the blood sugar throughout the night, okay? Because the people with the dawn phenomenon will not have those dips in their blood sugar. They will not experience hypoglycemia. Okay, we're going to talk about macrovascular and microvascular issues that come along when people don't control their diabetes. The macro, this has to do with your large to mid-sized vessels, okay? It has to do with the fact that the patient has not only not regulated their blood sugar, keeping their hemoglobin A1C where it should have been, but also a lot of times these individuals have hypertension and they're not controlling their blood pressure either. And so the patients develop issues with all these different arteries, which we've talked about the majority of these. They're at increased risk for developing coronary artery disease and peripheral arterial disease. And as you guys will understand too when you get to neuro, that they're also at increased risk for developing or having a CVA, which is a stroke. The microvascular damage that's done, this results from vessel thickening in the smaller vessels in the capillaries, and it is also due to an increase or an uncontrolled blood sugar, but it also can be due to unchecked hypertension in conjunction with that. So they have to have tight glycemic control for all of these. The retinopathy has to do with the eyes, obviously. So patients who have diabetes need to have their eyes checked at least yearly. They end up having retinal damage. There are different types of retinal damage that they can have. We're not going to get into the specifics of those, but just that you need to make sure your patients understand that we can treat this and have no vision changes as long as they keep their blood pressure and their blood sugar well controlled, see an ophthalmologist at least every year. And that's to have their eyes dilated and have them checked. Okay, there is treatment that can be done if they do end up with retinopathy, mainly in the form of laser photocoagulation therapy. It can help reduce the vision loss. We're not going to get into the actual procedure itself, but that is one of the treatments. The neuropathies is actually nerve damage, and so then the patient has lost sensory. And so this can be in any of the smaller vessels, and that's the neuropathy. We call it diabetic neuropathy. The majority of diabetics will develop this if their blood sugar is not well controlled. It often leads to loss in sensation in the lower extremities, and it can lead to many complications, including non-healing ulcers, infections, limb amputation. And so they get into the two different types of neuropathy that a patient might experience, but we're not going to get into those as specifically. And then we've also talked about the fact that the number one cause of end-stage renal disease is actually diabetes. And so we've already talked about end-stage renal disease, and we said, the two main reasons people develop end-stage renal disease is hypertension and diabetes. These are the nursing diagnoses that we're going to talk about in class. We're going to actually develop these in class, and so we're going to end the voiceover here. Just realize that there on your PowerPoint are NCLEX style questions that you need to complete and bring to class.